Welcome to TCCC-Plus, Day 2, Module 2, Foundations of Prolonged Field Care. This module teaches the mindset shift and the reassessment system, the 5 questions and the flow sheet. TCCC was built for a fight where help was close. Hand the casualty off within the hour. This module is about what you do when that handoff does not come, and the moment it does not come, you are already in prolonged care. Even if the casualty needs nothing else done, the clock alone has changed your job. As we discussed on day 1, there is a major difference between evacuation times and risks in conflicts with non-peers 10 to 20 years ago compared to a peer conflict today. Movement is now watched and targeted, so evacuation is routinely delayed for hours, days, sometimes weeks. This means the casualty stays with you. The golden hour has stretched into a golden week, and survival now depends on the quality of care over time, not just the first few minutes. Prolonged field care is not a fourth phase after the 3 we spoke of on day 1, CUF, TFC, and TACOVAC. It is what tactical field care becomes when evacuation does not come, and it involves sustaining a casualty over time. It is not hospital care, and this course will not make you a medic. Your job as a non-medic in PFC involves 4 things. Keep them alive, stop them getting worse, do not make them worse yourself, and keep a record so the next person can continue. And remember, the goal of prolonged care is to get out of prolonged care. The change from day 1 to day 2 that matters most is that in basic ASMT-CCC you apply interventions. Quickly and a bit by rote, tourniquet on, seal on, move. In PFC, you switch focus to maintain and reassess. This because the biggest killer over time is not a dramatic new injury, but a controlled problem quietly coming undone. This includes loosening tourniquets, hypothermia, infections, and gradual airway compromise. Catching that while you can still prevent or treat it requires reassessment. The doctrine has a backbone for organizing care over time. This is worth knowing even at this level because it tells you what to set up and in what order. Master the basic TCCC first and keep resuscitating. Name a team leader, someone who holds the whole picture while the others do the hands-on tasks. Do a proper head-to-toe exam and build a problem list and a plan from it. Start trending vital signs as early as possible. Get a teleconsultation going as soon as you can. Make a nursing plan early because most of the harm over a long hold is the slow, preventable kind. Build in rest, food, and a moment to think for the team, because tired responders make mistakes. Anticipate running short of supplies and power before you do, and step back at intervals for a quick round of the casualty. Reassessment in prolonged care runs on the 5 times we mentioned on day 1, on a schedule, after every intervention, after every move, on any change, and at handover. Those are the triggers for reassessment, and missing them may mean the casualty drifting without you noticing. At each of the 5 times, step back and run 5 questions regarding March Pause L and especially previous interventions. Stable or unstable, are the vitals holding or sliding? Sick or not sick, your overall read of how bad this is. Better or worse, the trend against your last check, because a trend tells you more than any single reading. What is different from the last time I checked? This is the question that catches the slow killers, the tourniquet working loose, the airway filling, the casualty cooling. And the last question, what am I going to do about it? An answer you do not act on is not useful. And write the result on the card every time. The flow sheet is the memory of the hold. Here are the 5 questions on a loop. Round again on a set cadence. On a long hold, the casualty who was fine an hour ago is the one who kills you if you stop asking. And write it down on a card that stays with the casualty. Time and mechanism, March Pause L status, the trend in their breathing, pulse, mental status, temperature and pain, tourniquet times, and every medication with dose and time. Again, a trend tells you more than any single reading. When not medically trained, it is all the more important that you stick to your lane. You assess and reassess, control bleeding, position airways, seal chest wounds, prevent hypothermia, give pain relief and antibiotics by protocol, dress wounds, splint, document, and hand over. You do not intubate, perform surgical airways, sedate, or give anything outside protocol. For things that are past your scope, that is what telemedicine and the handover are for. Thanks for watching Module 2 of the TCCC-Plus course, Day 2, Foundations of PFC. Next up is Module 3, Massive Bleeding Reassessment.